Hello and welcome to our high-yield review of mechanical ventilation. If there's one topic you absolutely must know inside and out for the CCRN exam, this is it. Today, we are going to break it down into simple, memorable concepts, focusing on what you truly need to know about modes, settings, alarms, and weaning to answer any question that comes your way. Let's get started. To start, let's simplify. Every action we take with the ventilator is aimed at achieving one of two goals. First is oxygenation. This is about fixing a low PaO2. Think of it as opening up the lungs and getting oxygen across the alveolar membrane. The two settings that control oxygenation are FiO2 and PEEP. Second is ventilation. This is about fixing a high or low PaCO2. Think of it as simply moving air in and out to blow off carbon dioxide. The two settings that control ventilation are respiratory rate and tidal volume. Here's the key CCRN tip. When you get a question with an ABG, the first thing you should do is decide, is this an oxygen problem or a CO2 problem? That will immediately tell you which two settings you need to focus on. Let's look at those four settings more closely. FiO2 is the percentage of oxygen we deliver. It's the fastest way to increase PaO2, but be careful. FiO2 greater than 60% for too long can cause oxygen toxicity. PEEP, or positive end expiratory pressure, keeps the alveoli from collapsing at the end of exhalation. This improves gas exchange and is our best tool for treating refractory hypoxemia, which is the hallmark of ARDS. Respiratory rate is the number of breaths per minute. To fix a respiratory acidosis, meaning a high CO2, you increase the rate to blow off more CO2. And tidal volume is the size of each breath. A larger volume also helps blow off more CO2. The big exception, which is a favorite exam topic, is in ARDS, where we intentionally use low tidal volumes for lung protection. Now let's talk about modes, starting with volume control. In these modes, you guarantee the patient gets a set tidal volume with every single breath. The trade-off is that the pressure needed to deliver that volume will change based on how stiff or compliant the lungs are. The most common mode is assist control, or AC. In this mode, every breath is the full, preset tidal volume. It doesn't matter if the patient triggers the breath or the machine does. This provides maximum rest, so we use it for critically ill patients in shock or ARDS. The main thing to watch for here is breath stacking, which can lead to respiratory alkalosis. The other volume mode is SIM. Here, the vent gives a set number of mandatory breaths, but in between, the patient can take their own spontaneous breaths at whatever size they want. This is primarily used as a weaning mode to make the patient start using their respiratory muscles. The opposite of volume control is pressure control. In these modes, you guarantee a set inspiratory pressure. The trade-off is that the tidal volume the patient receives will change with every breath depending on their lung compliance. Pressure control ventilation, or PCV, is the go-to mode for lung protection in ARDS. By setting a maximum pressure, we prevent the barotrauma that can happen in stiff, fragile lungs. The key nursing responsibility here is to constantly monitor the exhaled tidal volume to make sure the patient is still getting adequate ventilation. Finally, pressure support, or PSV, is a pure weaning mode. The patient has to trigger every single breath, and the ventilator just provides a little boost of pressure to make breathing easier. This is what we use for spontaneous breathing trials. You are guaranteed to get a question on ventilator alarms. The easiest way to think about this is obstruction versus disconnection. A high-pressure alarm means there is an obstruction. The vent is trying to push air in, but something is blocking it. Think through the causes from the patient outward. Are they biting the tube, coughing, or full of secretions? Is the tubing kinked? Or is there a serious problem in the lungs, like a pneumothorax? Your first action is always to assess the patient. If they are unstable, disconnect them from the vent and start bagging them manually. A low-pressure alarm means there is a disconnection or a leak. Air is escaping. The most common cause is that the circuit has simply become disconnected from the patient. It could also be a cuff leak or, in the worst-case scenario, an unplanned extubation. Before we can extubate a patient, they have to pass a spontaneous breathing trial and meet specific criteria. You need to know these numbers. The single most important predictor of success is the Rapid Shallow Breathing Index, or RSBI. It must be less than 1/5. Next is negative inspiratory force, or NIF, which measures respiratory muscle strength. It needs to be a strong negative number, greater than -20. The patient should also have a good spontaneous tidal volume and, of course, stable vital signs and ABGs on minimal support. Okay, let's apply this. The high pressure alarm on a patient's ventilator begins to sound. The patient appears anxious and their SpO2 is dropping. What is the nurse's priority action? A. Immediately suction the tube. B. Silence the alarm and check for kinks. C. Disconnect the patient and manually ventilate. Or D. Administer a sedative. Feel free to pause the video to consider your answer. The correct answer is C. This is a critical safety question. When the patient is showing clear signs of distress like anxiety and desaturation, you don't have time to troubleshoot. The safest and fastest action is to take over their breathing manually with a bag valve mask. This ensures they are safe while you figure out the underlying cause. The other options are all things you might do, but only after you have stabilized the patient. Let's try one more. A patient with ARDS has the following ABG: FH7.25, PACO 258, and PAO 285. Their vent settings are AC mode, rate of 16, tidal volume of 350. Which ventilator change would most directly address this patient's primary acid-base imbalance? A. Increase the PEEP. B. Increase the FiO2. C. Increase the FiO2 rate. Or D. Decrease the tidal volume. Again, you should pause the video to consider your answer. The correct answer is C. Let's break it down. First, interpret the ABG. The low pH and high PaCO2 tell us this is a respiratory acidosis. The PaO2 of 85 is perfectly fine, so this is not an oxygenation problem. It is a ventilation problem. They are retaining CO2. The two settings that affect ventilation are rate and tidal volume. To get rid of CO2, we need to increase one of them. Increasing the respiratory rate to 20 is the most direct way to correct the respiratory acidosis. Let's summarize. First, remember oxygenation versus ventilation. FiO2 and PEEP fix oxygen. Rate and tidal volume fix CO2. Second, know the difference between volume and pressure control. Volume control gives a set volume, while pressure control gives a set pressure. Third, for alarms, think obstruction versus leak. High pressure is a block, low pressure is a disconnect. And finally, memorize those key weaning parameters, especially an RSBI of less than 105. And that's it for our high-yield review of mechanical ventilation. Mastering these core concepts is absolutely essential for the CCRN. Review this again, do some practice questions, and you will be fully prepared. Thank you for studying with us. Good luck on your exam. You've got this.